You can ask any nuclear medicine technologist about the most common procedure performed in nuclear medicine, and I'm quite sure that the answers will be the same, and that is a bone scan. In this video, we are going to take a deep dive into the procedure, the radiopharmaceutical used, and the scanning procedure itself. Hello everyone, this is Patrick, and this is your beginner's guide to bone scans. A bone scan is a nuclear medicine procedure that detects conditions or pathologies in the bones. A radioactive tracer is injected into the patient, and the scan is performed after a few hours to look for any abnormal uptake that may indicate a condition. Before we go into the procedure itself, we should talk about the most common radiopharmaceutical used for this procedure, which is TC99M HDP. I know it's a bit of a jargon, but TC99HDP stands for technetium-99M dihydroxyphosphonate. When a part of our bones gets injured, our body immediately tries to repair itself from fractures, arthritis, bone infections, and most especially bone metastasis. The body will try to sort of fix it, and it will need a raw material, and that is where HDP comes from. HDP, once injected, becomes a pseudo raw material, attaches to the hydroxyapatite crystals in the bones, and gets absorbed during the process of remodeling. With a tagged radioactive tracer, it can now be detected by the gamma camera. It is expected that the tracer will be absorbed by the bones. If there is any condition or pathology present, it may be demonstrated by increased or decreased uptake, increased vascularity, and increased deposition of the tracer in the tissues during the blood pool phase. Just like any other tracer, it needs to be dispensed in a laminar flow to ensure their cleanliness and sterility. The settings such as the isotope measured, time, and the procedure needs to be checked and cross-referenced. The dose and the time measured should also be correctly recorded. Just to simplify, let's categorize them into two classifications: a standard bone scan and a three-phase bone scan. A three-phase bone scan starts with the flow phase, wherein the tracer HDP is injected while the area of interest is under the detector with the commencement of the dynamic acquisition. After 10 minutes, a static acquisition of the area of interest is acquired, which is also called the blood pool phase. The late phase is where we scan the patient under the scanner after a few hours from the time of injection. A standard bone scan involves injecting a patient with a tracer and waiting for a few hours before performing a whole body scan, statics, or even a SPECT CT if needed. Nicola, an advanced nuclear medicine practitioner, will be explaining to us in detail on how to do a bone scan.
So essentially the patient would come into the department. Before we bring the patient through, we would look at the clinical details for that patient and make sure the referral details are suitable for that scan. We'd also check that the scan has been authorised or justified by somebody, by a doctor who has the ability to do that. Then we'd bring the patient into a clinic room. We would check the ID of the patient by checking the name, the date of birth and their address. We would then have a chat to the patient and just ask them a question to make sure that their clinical history matches what the request says. And then we would explain what the procedure involves. And then we would ask them some questions. In this department, we have set questions that we ask. The main reason we're asking the questions is because the bone scan is generally a sensitive test, but not a very specific test. So if they've had any recent falls that could involve or any recent fractures, it's good to have that clinical history to match. So when the doctors are looking at the pictures at the end, they can match the patient's history to the images. We would then pop a cannula into the arm or into the hand, and through the cannula we inject 600 megabecs of HDP. We would then advise the patient what time to return. In our department, we give a time 3 hours afterwards. We would also request in that time in between the injection and the scan that the patient drinks plenty of water and empties the bladder frequently, just because it improves the quality of the pictures that we give. So the free-phase bone scan we tend to do on patients if we're specifically looking at joints. So this could be like if the clinician's querying whether it's an infected prosthesis or whether it's rheumatoid arthritis or inflammation of the joints. The start of the procedure would be the same. We'd still check the clinical indication was relevant. We'd still ID the patient. We'd still bring the patient, but instead of bringing them into the clinic room, we would take them straight into the camera room. We'd explain the test to them, ask them exactly the same questions, and then we would ask them where the area of pain is greatest, if it's a generalised joint pain. So, for example, a lot of patients will have shoulder pain, knee pain, hip pain, but we'd identify which is the most painful joint. And then we would position the patient under the camera, focusing on that area. We then inject the HDP tracer with the patient under the camera, and we start taking pictures straight away. We would then take a dynamic, and then we do a static after that of what we call a blood pool, and then we would also do a whole body blood pool scan after that. And then that normally takes about 15 minutes or so, 10-15 minutes, and then we would then get the patient off the bed and say we'd give the patient a time to come back, which would be 3 hours later for the delayed images. This is one of our gamma cameras. So when a patient returned after the 3 hours, we would bring the patient into this room. We would check their ID again, so name, address and date of birth. We'd also ensure that the patient had no big metal items around the body, so we'd ask them to remove belts, watches, coins, keys, anything like that in the pockets. We'd then get them to lie down on the scanning couch, so the head would be positioned about here and the feet would be about here. We also get the patient to remove their shoes, and we try to position the patient in a pigeon toe position, so as though their feet are out and their toes are touching. And we tend to put a strap around the feet to help them maintain that position. We then press set on the camera, which raises the bed, and then the bed moves into the camera and the camera heads rotate around. For a lot of the patients, we would start off and do a whole body, so from the top of the head to the bottom of the feet. If it was a joint prosthesis scan, we may reduce that scan. For example, if they were looking at a knee replacement, we would just scan from the hips to the feet. So you have to review the clinical information to see what area we'll be focusing on. So once in this position, we would ensure the top of the head, if we were starting from the head, is all visible on the ppm here. If we were happy, the camera heads would then move in, and then as the patient was happy, we would then start the scan, and the body contour would then continue to work, so the camera heads would come as close as they can to the patient, but without touching them, and the bed will just gradually move outwards until we've scanned the patient from the area of interest that we've wanted to acquire. So most of the time, like I say, that would be from the head to the bottom of the feet. Okay, so you'd select the patient. Obviously, this where it says test would be a patient's name, so you'd make sure you've got the correct patient selected. Then you would then select the whole body protocol. So the first scan we have set up is a whole body. It acquires the anterior and posterior simultaneously. We need to make sure the use body contour is ticked in order to make sure that the body contour is functioning during the scan. And we scan at 10 centimetres a minute for a whole body. In this department, most of the time we would acquire the whole body scan first and then review the images with the doctors, and then they may ask for additional pictures. So we have set up some static images, so if they wanted additional pictures, for example, oblique ribs or medial lateral knees, we can edit this information in order to acquire whichever statics we needed. And then we also have a bone spec CT protocol set up as well. Again, in this department, for the majority of times, that would have to be authorised by a doctor. So we would have to get that checked for them to say what area they wanted us to acquire. The SPECT CT is set up to do 50-second frames, and then it goes into the CT scanner afterwards.
Most of the time, a standard bone scan is done looking for bone metastasis in oncology patients. Patients who have been diagnosed with cancer undergo this process to check whether their cancer has spread to their bones, which helps with the diagnosis and prognosis of a patient. On the other hand, a 3-phase bone scan is performed with patients with certain conditions such as arthritis and infections. Patients with unexplained pain in their joints or even infected prostheses may be detected with this procedure. Let's now discuss the protocol itself. Please remember that there may be similarities and differences in protocols from hospital to hospital. Just like any other hospital, we always perform the patient identity check to ensure you're speaking to the correct patient. Getting their history is a vital part of the process. Understanding the patient's condition may provide you with the information necessary to determine which protocol you should use. After the conversation, we administer the dose intravenously using a butterfly or a cannula. After the administration, the patient needs to wait at least 3 hours before the scan. When the time is up, the patient is asked to lie down on the gamma camera. From there, we position the patient under the gamma camera and slowly the patient emerges while the machine scans the area. After the whole body scan, we may perform additional static images. These are like pictures of specific body parts to provide a better view. In some cases, static views are not enough and we need some detailed images, which is where a SPECT CT comes in. In a nutshell, a SPECT CT acquisition involves combining a SPECT and CT images into one to create a 3D version. This allows us to locate and enhance images of particular organ or region. In cases of arthritis or bone infections, the approach is slightly different. This is where a 3-phase bone scan comes in. Then the involved parts of the body should be positioned under the detectors. We cannulate and inject the tracer and perform a dynamic acquisition. A dynamic acquisition is basically acquiring multiple images and recording them as the tracer enters the body. After 10 minutes, a static picture is taken. For the delayed phase, we will initiate a whole body scan, during which the patient will be scanned from head to foot, followed by some static acquisitions. A SPECT CT might be necessary, which may require further justification if needed. The images are processed, saved, and available for the consultant to review. I hope this guide helps you on your journey to become a nuclear medicine professional. Feel free to share any thoughts or suggestions you have. If you enjoyed this video, please give it a thumbs up and subscribe for more. Cheers and see you next time.